right, thank you all. We're going to get started on our last presentation for the day, and this one is really a wonderful wrap-up because it really takes it from not just professional that we are as professional advocates, but it brings in our clients and who we're really doing this for. Okay. Today is going to be a joint discussion between Emily and Shay on the patient perspectives, searching for a diagnosis and navigating chronic illness as a woman in the U.S. And so I hope you take lots of notes, and we'll go ahead and get started with this. Would you two like individual microphones, or do you want to stand up there? I'll stand up. Okay.
All right, hello. So, my name is Deb Gordon. No, I'm joking. Deb had to step out, so once I heard about the topic of this session, I was delighted to step in. My name is Chandel Acosta. You can also call me, and probably have met me as Shay. I am an independent patient advocate, board certified, and I have a company called Autonomy Health Advocacy based in the Bay Area. I am a proud member of AFA, Bay Area Healthcare Associates, GNA, all the normal ones, right? But I also just wanted to note that I identify as agender, which is kind of on the non-binary spectrum. So as I'm presenting some of these statistics, I don't want to misquote any wonderful institutions, but you can assume that when I'm talking about women, it's people who were assigned female at birth. Okay? Cool. And then Emily, do you want to introduce yourself now? Okay. Cool.
Hi everyone, I'm Emily Rubenstein. I was diagnosed with hypermobile Ehlers-Danlos syndrome and endometriosis about 2 years ago, and I am honored to be here sharing my story to diagnosis and some of the challenges that persist post-diagnosis as well. So just really honored to be here and have this chance to talk with all of you. So turn it back over to Shay.
Amazing. Technology. Okay, so I'll give you a second to just see Emily's information. All right, so we are going to start just with some context. Chronic disease in women, or AFAB folks, is obviously more common. On average, it's about 3% more common. About half of women in the US have at least one chronic condition, and then the percentages, continue on as you compound with more conditions. Importantly, when you intersect the factors of race, it gets even worse. About 1 in 5 women report poor or fair health at best, and data from Kaiser Permanente shows that women of color just generally report worse health stats. The long road to accurate diagnosis. So for men and women that have these same conditions, so with other aspects controlled for, women wait longer on average between the onset of their symptoms and their diagnosis. So not only are they waiting in order to pursue treatment, they are also waiting for longer appointment times, they are waiting for doctors to believe them. So on average, it takes 4 years longer for women to be diagnosed than men. An example in the autoimmune disease sector is that 80% of the people with autoimmune conditions are women. Autoimmune patients see 4 doctors over about 4 years before they can even reach a diagnosis, let alone being, receiving appropriate treatment. And so, as many of us have probably experienced throughout that journey, it's not just a matter of waiting, it's a matter of being told that we are just complaining. It's a matter of having our experience invalidated. It's just, it can be a dehumanizing and extremely vulnerable experience that can lead to a lot of trauma within the medical industry and can essentially be a continuous cycle of women not advocating for themselves and delaying their treatment further. Let's see. So this is a quick anecdote. So this patient perspective was a person who was struggling for diagnosis. This quote is from her story. "I went from being incredibly healthy to being incredibly unhealthy. There has to be a connection. I feel brutalized by the medical system. They can never figure anything out. They just keep cutting pieces out of me." So this woman was at one point a weightlifter, like an extremely healthy, fit, and just healthy lifestyle individual. She was in her 40s and had cascading medical problems involving multiple systems. She was unsure if it was coincidence, if it was connected, if it was autoimmune conditions. Some of them did turn out to be autoimmune, but it just did continue to impact from there. And so over the course of multiple years, she consulted with multiple specialists, she got no answers, and eventually she just felt exhausted, broken, lost, scared. And again, this is not an uncommon experience. Her comorbidities might be less common, but the fact of being just brought through the ringer with the medical system is one that many of us face, many of our patients face. It's why many of us are here today. And so bringing light to this, I think is a big part of potentially our mission. And it's important to highlight stories like these so people know that not only are they not alone, but that it is a systemic issue that requires attention. All right. So, women rate their access to treatment through insurance at a D-. 1 in 10 non-elderly women in the US are uninsured. 19% are covered by Medicaid. Women with insurance report problems getting coverage. And while some of them believe their plans would cover care, many of them think that it won't. Many of them are afraid that it won't, and so this causes further delay in care. Many of them have also just experienced additional or more frequent denials for their care. So they'll be submitting or pleading with their doctors. They'll be going through the system the way that they think they're supposed to go, or the way that they are supposed to go through it, and still be getting denied at this part of the journey as well. Part of that is the gender tax. So, healthcare costs hit harder for women than for men. Women are more likely than men to put off care because of the cost. 27% of women report trouble paying for healthcare versus 20% of men. I don't think I need to bring up the wage gap, but there you go. But even aside from that, with insurance, 50% of women have delayed their needed care, and 35% of men have delayed their needed care. Now, when you think of that statistic, you're like, okay, well, maybe that's why men are getting treated faster. It's not. The delay in care that men experience is actually controlled for. So despite men going for care later in the progression of their disease, they are still seen faster, not due to the severity of their disease, but due to, I guess, what's in their pants. I don't know. But if people with the same disorders go into the same room, ask for the same treatments, you're more likely to be seen faster and be approved and therefore have more coverage. 40% of women have skipped recommended tests or treatment versus 26% of men, and women pay on average $15 billion more per year in out-of-pocket healthcare costs. So the 20% more does exclude pregnancy-related care. In fact, the higher utilization of healthcare services is true. Women do use more healthcare services, in part because we experience more chronic conditions. And the maternity aspect is often raised as a big factor in that. It accounts for less than 2% of the differential in spending. And so looking at the fact that women are using more healthcare and require more healthcare, you would think, well then, sure, it makes sense that they require more coverage and they should pay for that coverage. The challenge here is to flip that perspective, because if over half the population requires more coverage, why is the system designed for the minority, right? So increasing that coverage so that the same benefits have the same amount of value to everyone in the system is a good target, right? So, so part of this also is just important. It's important to recognize that when conditions are being paid for and when a standard of care is determined, it is based on research, hopefully, right? And until, I don't know, I guess past few decades, some of you will definitely know more solidly than I do, the majority of that research was only on men, and primarily men who were not of color. So these are the things that are the foundation of our medical system. We are trying to hopefully shift that and try and make it more inclusive and better for everyone. Let's see. So likewise, financial toxicity, meaning the longer term impacts of the financial burden. Women rate their experience worse in terms of the financial impacts from their healthcare costs. 56% of women had trouble affording their bills. 48% of women worry about unexpected bills. And if they can afford that, 56% said that they can afford less than $500, but 39%, said they can afford. Okay. 26% of women experience financial hardship due to chronic conditions versus 20% of men. So women do use more services, as said, particularly radiology, labs, mental health, ER, office visits, PT, OT, chiropractic, etc. But the higher utilization, being the main driver again, excludes maternity, which is usually what is cited. All right. And then this is, this was going to be an anecdote about another patient, but I am actually going to shift it a little bit to a personal one. So I have endometriosis, and the patient who gave this quote also had endometriosis. She had stage 4, I have stage 3. And if you don't know, that means that for me it was pretty severe, probably will be again one day because it's progressive, but it was contained within a single region of my body. I started my period when I was 11. I was starting to experience pain by the time I was 15. I had debilitating pain by the time I was 19. And then by the time I was 29, it was debilitating to the point that I would be bedridden for 3 to 4 days of the month, using the maximum, just even safe amount of over-the-counter medications, using heating pads, topical analgesics, everything that I could. And so it took another year after that for me to feel comfortable even investigating it more, in part because of the social conditioning that, you know, we have to tough it out. Like, we have to just keep going. Women all experience pain during their periods. Why should I pay more attention to mine? And even once I got over that, even once I got into advocating for other people, I was still afraid of the cost. So it was not something that I was willing to take on until, you know, I was fortunate enough that my spouse worked for a big commercial tech firm, and so was able to get good insurance for us. And so under their insurance, I was able to be seen with some peace of mind that I might be able to afford it, but I still wasn't sure. So once I decided that I would finally pursue it, it still took me 2 years to get treatment. It was 2 years of talking to doctors, getting referrals, having exams. Endometriosis, as you'll hear more about, is a little tricky in that you can only diagnose it clinically through surgery, so that's fun. But it also leads to the aspect that many of our chronic conditions have, which is that they're invisible illness, right? So they're contested, they are just adding to the stigma that the things that are happening in our bodies are also in our mind. And so I was fortunate. I was able to get treatment. I was able to have surgery 2 years ago at this point. And my quality of life is much better now. I think I had probably a better turnout than many people have, even with what I've got going on. But part of that is that I was in the Bay Area. People generally believed me when I first brought it up, right? Sorry, Bay Area of California, I should specify. Not Green Bay. There's a lot of people from Wisconsin here. Okay. I was believed also because I am an advocate, and I was by the time I was going to see these doctors. At the time I was working for nonprofits, so I wasn't doing quite the type of work I'm doing right now, but I knew how to make sure that my voice was heard, and I knew how to ask good questions. I also knew how to find good doctors, and I made sure that I had a doctor who was a woman of color, who was also queer, who believed me, and sent me referrals to people who were like-minded and who really understood all of the social determinants of health that were at play. And that led to a surgeon who led to another surgeon who took my case and was very patient and really maybe even extra patient, because we're probably all more curious than most patients, in explaining everything to me, helping me understand all of my options. And so I would even take it one more step further and just say, like, I'm an advocate in large part, and I know to ask those questions in large part because I had a rather elite education, which is thanks to the fact that, I had family members who had good enough credit to get loans, I had time to go to college and focus on that. And that is not a thing that everyone has. So I just want to point all of that out, make it very clear that it is so hard for so many people. And even people who are the most equipped, who have the most support, and just know exactly what to do, or at least, the best they can as like a 30-year-old, they still struggle. And we're still here. And we'll keep going, because we gotta. And on that note, I give you the fabulous Emily Rubenstein.
It's like kismet that we ended up doing this session together, and I'm so excited to share the stage with Shay. And you're going to hear a little bit of repetition because some of my experience was somewhat like Shay's. But whenever I think of sharing my story, I always like to start here. This is my map of what it took for me to get my diagnoses. I'm not going to take you step by step. We would be here past when your flights are taking off. But just as a quick illustration that this is what so many people with invisible chronic illnesses go through in trying to find answers. So just let that sit there for a minute. And while I do, I also want to mention a few things before I move on, and just emphasize that these steps and my journey are my own, just like the way that my illnesses have presented in me. Even if what I share seems overwhelming to you, and of course it has been very overwhelming to me over the years, it's imperative to underscore that this is an example of moving through the medical system as someone with immense privilege. Privilege that comes from being a white, cis American daughter of a doctor with an Ivy League education, relatively good insurance, and who knows a lot of providers, both socially and professionally outside of my care team. So as I walk through my story, I invite you to think about all of the layers that could be put on top of what I'm talking about that so many women have to contend with beyond what I had to contend with myself. So here's a few personal stats, my personal baseball card. I was diagnosed with endometriosis and hypermobile Ehlers-Danlos syndrome almost 2 years ago when I was about to turn 30. For those unfamiliar with HEDS, the EDS Society defines it as a heritable connective tissue disorder that causes generalized joint hypermobility, joint instability, and chronic pain. So as a quick example, my joints are really bendy. You can kind of see my fingers going backwards. And although it took me so long to get diagnosed with HEDS, I was only 12 when a provider first mentioned hypermobility to me. It took 17 years from then for a provider to actually guide me toward thinking that this might be an explanation for so many of the symptoms that I was experiencing. And even once I got to those providers who were knowledgeable about HEDS, it still took me 1.5 years to get my diagnosis. Similarly, I was also about age 12 when I started my period and had excruciating cramps. I empathize with what Shay was describing, having trouble getting out of bed. I have a vivid memory still of writhing on the floor in the fetal position of the family room in my parents' house because of the pain that I was in and just not really knowing what to do except cry. I also took a lot of over-the-counter pain medication and was basically told that's just what I should do. Like the number of pills of Advil and other things that I've taken, like I don't even know, it would fill like this whole room. Yeah, exactly. And so I was put on birth control, hormonal birth control, pretty early on, which of course caused other problems down the road. But as far as I can remember, endo was first mentioned to me explicitly as a possibility for what I was dealing with in 2019. But since the provider thought that the symptoms I was experiencing weren't severe enough, and the only way to confirm endometriosis was through surgery, she said I was doing all that I could, and there was really nothing for me to do. It would take 3 more years to recognize that the GI symptoms that I was experiencing were actually related to endometriosis, which I had on my rectum, as well as in other places, to get the surgery that I needed and have my symptoms lessen. So during my diagnostic search, I saw over 22 specialists and over 16 specialties, and that was just before I got the names of what I was contending with. And for so long, I was playing whack-a-mole, trying to address each of these individual symptoms, because no one had really ever suggested that there might be a whole body explanation for what was going on. So as you can imagine, playing whack-a-mole with this number of symptoms, and probably others that I forgot to even put up there, was really exhausting. It was more than a second job, and I went through continuous boom and bust cycles, trying to get answers, getting appointments to referrals to other specialists, to more tests, to more scans, to more, you name it, being exhausted and having to take so much time off of work that I needed to then focus on work and resting. But then I got worse and really had to continue to focus on having the appointments and just on, rinse and repeat, rinse and repeat. But the turning point for me happened in January of 2021. I was laying in bed, it was evening, and I had really bad abdominal pain, which is not uncommon for me, right? At this point, I'm kind of used to being in pain a lot of the time. And so I didn't know if it was just like my normal pain or if something was going on. It felt like maybe slightly different. So I called a couple of doctors I knew, and they walked me through kind of an at-home appendectomy test, or appendix test. And it came back negative. So in talking with my boyfriend, we decided I would try to sleep on it, see if it resolved in the morning, and if not, then we would do something about it. So I stood up to get ready for bed, and I almost fell over because of the pain that I was in. And that was when I realized that I really did need to go to the emergency room. So I go to the emergency room. Surprise, surprise, it turns out that it is my appendix. And just like so many other things in the world of hypermobile Ehlers-Danlos, something was just a little different. And in this case, my appendix was just slightly in a different place, so that at-home test didn't catch what was going on. But what really stood out to me through this experience is that the attending in the ER scolded me for not coming in sooner, for not knowing that the pain that I was feeling meant that something was actually wrong. And that really hit me in the fact that I had normalized that level of pain on a daily basis. And I knew then that I really could not continue in that way. So I continued to push for answers. And you can see here the final steps to my major diagnoses, which luckily came in the next few years. But it continued to be a struggle in all different ways. And I want to take a moment just to talk about the importance of diagnosis, because there are many providers out there I've heard say, well, if it's a chronic illness and there really isn't that much to do, like, why do you even need an actual diagnosis? Is it worth going to the appointments and getting a name even if there isn't anything to do? And I just so disagree with that. Diagnosis is so helpful in so many different ways. The first being that it gives you community. It gives you a place to get to know other people who are experiencing the same things as you. Some of those people in my community are actually here today. And it gives you a space to be you. You don't have to mask. You don't have to pretend to be okay when you're not okay. And when I first got my diagnosis, I even started just following people on social media who had endometriosis, who had EDS, and having those touch points gave me a sense of hope and gave me, tips and tricks and things. And I've made some of my best friends now in waiting rooms. One of them actually gave me this necklace that says "Nobody fights alone," and it's just a way to be connected, a way to no longer feel like you're on your own fighting this battle. And another way that it really helps is that it gives you an existing vocabulary. You don't have to try to convince people or come up with the right words to explain what's going on, and you don't even really know what's going on. So having that vocabulary can help in many different ways in making accommodations requests, because there are people who've come before you who can help you understand what might help, and also the language to advocate for yourself. It makes pacing and setting social boundaries a lot easier because you can explain to people a little bit more what's going on. And that's so especially important for people with invisible chronic illnesses, because as she was kind of saying before, like, you can look fine or have it all in your head, but once you have this vocabulary, you have this ability and this growing confidence that the community gives you, you're much more able to advocate for yourself. It also provides an illustration to the medical industry that there are patients dealing with this. There's a growing population, and there are people who are looking for innovations in this space, and I think that that's a really important point, that it allows people in the medical field to understand that there are people who want to see progress in these areas. So, continuing challenges, post-diagnosis. People like problems to be solved, right? Like, it's nice when problems are solved. And whether it's a friend or a boss asking if you're better yet, or an insurance company wanting to see progress in your physical therapy to make sure that they are going to continue to cover the cost of them, society wants people with chronic illness to magically get better soon. We know that that's not going to happen. There is no magic fix to chronic illness. And so I'd like to argue that we should move from chronic illness care focusing on this fully cured expectation, this societal expectation that, oh, if you do a few things and you like do your exercises and stuff, like, you'll be better, you'll be fine. to focus on more improvement and management. Finding environments that accept that kind of mindset, especially in our society, can be very challenging socially, medically, financially. And there's also a dearth of knowledgeable providers who are accessible to people with HEDS and endometriosis. When you're lucky and identify a provider, and even luckier to identify a provider who actually is accepting new patients, that provider is almost certainly not going to be accepting insurance. Insurance is not going to cover that visit. I usually hit my out-of-network, out-of-pocket maximum in February at the latest, and I know that many of my chronic illness friends are in the same boat as me. Those with endo and HEDS also experience medical gaslighting and trauma, and I'm no exception. I know Shay talked about that as well. I had a male gynecologist tell me my pain was normal. When working with new PTs, I continue to struggle with anxiety and shame because of the number of years that I spent being assigned home exercise programs that when I went home and did the exercises would cause me lingering pain, lingering headaches, and would interfere with my ADLs. So when I would go back, the providers would make me feel bad that I was a personal failure for not getting better from doing my exercises. But that wasn't my fault, right? I was getting the wrong exercises, but that's still the constant feeling of being wrong or not doing the right thing when you know that you're fighting for your health can become so ingrained in you that it takes a really long time to move past. But my most traumatic experience was the first time I went for an IUD insertion. So, as you all know, I'm sure, IUD insertions are not fun to begin with. I went in and I got the IUD inserted, and I was left alone in a treatment room, door closed. A few minutes later, I don't actually know how long, my body had a vasovagal response, and it actually effectively went into labor to push the IUD out. I know that I'm not the only person who's experienced this, but I was alone in this room, door closed, trying to call out for help, and no one came. When they finally did come, as far as my memory serves me, they thought that I might need some sugar. They gave me a piece of candy to see if that would help, while of course my body is continuing to, do the contractions and all that. When they realized that that wasn't going to work, they had me stand up from where I was, walk across the hall, and do an internal ultrasound to check the placement of the IUD. For someone who I now know has vestibulodynia, that of course was an additional, a lot of pain, in addition to what was going on as the contractions continued and all of that happened. They determined that the IUD was in fact not in the right place, made me stand up, walk back to the treatment room. They removed the IUD and sent me on my way. And I remember just in shock, walking on the sidewalk, really not understanding what had just happened. And a little while later, when the bill came in the mail, they tried to charge me for not only the IUD insertion, but also the IUD removal. And just the callousness of trying to charge me for that removal just underscored to me how little that provider in their office cared about me as a human and how much they were focusing on the business side of medicine. So, what can you all do to help us? This is an obvious one, but listen to your clients, validate their experiences. There are so many women with invisible chronic illness who maybe that will be the first time that they feel heard. So make sure to take the time and sit with them, listen to them, validate them. Continue to learn more about these different conditions. And even if you aren't an expert in them, that's fine. Just make sure that you know how to navigate some of these challenging diagnostic journeys, some of these challenging ways of getting treatment. And one of the main ways to do that is to help patients plug into the right place. You don't have to hold all the answers, but knowing who does is so important. Help find the providers who are not only knowledgeable, but compassionate for people with endometriosis and HEDS. Help them find the local Facebook groups where people share their experiences and their opportunities to get together, or connections, tips, tricks, all of those things. And ready yourself to support patients through all of the various things that require really complicated paperwork. As someone who had to go out on medical leave, it's really overwhelming. And I didn't even really know that patient advocates were an option for me. So I talked with my HR, and they luckily were pretty helpful, but not everybody's gonna have that experience. And even though they were helpful, I still felt kind of lost. So just be ready to be that person to help carry the client along. And like I said at the beginning, this is my experience that you've just heard. Everyone is going to have a different constellation of symptoms, and just be creative. Get ready to, dig in and work with the client, as I know that you all do. So I'm kind of preaching to the choir here, but it's so important, especially for patients who have had that medical gaslighting, have had that trauma, to really feel supported in the steps that they need to take. And I'm going to invite Shay up here to talk about a few more things. Or sit there.
Cool. It is hard to read the slide that's over there. So here we are. So things that we can advocate for, right? So on the structural and systemic level, we've talked a bit throughout the presentation about things that we can look for: creating, encouraging, training, and diversifying care teams. Congruence and diversity benefit everyone. Making systems work for minorities benefits the majority. And so it is not a matter of trying to replace anything. It is a matter of equity and bringing up the standards that we accept. Defining women's health beyond reproductive care to include conditions that only or differently and or disproportionately affect women and AFAB folks. Funding R&D to improve women's health. I know there's been a lot of wonderful presentations at this conference, both of organizations that are rallying. There's like a March on Washington next week or something I heard about. There's all sorts of ways to talk to your local legislation, be on boards, try and create a lot of community so that you can spread the word about these things and hopefully make change, right? We can make it easier to access treatment and testing, especially for hard to diagnose conditions. Insurance reform is always going to be a big part of that. And we as advocates can have a really big hand in that. As Emily said, like just really listening, validating, getting to the source of what women are experiencing so that we can better direct them to solutions that will not only heal their bodies, but hopefully their souls. And cultural and behavioral change. We can seek diverse providers and representative care teams and institutions. I think Dr. Rochester was talking about the importance of, and I'm sure many people talked about it, the importance of having care teams, if you can, that reflect you or that reflect your clients and patients whenever possible. Acknowledging and addressing the biases that you carry, implicit or otherwise, and trying to work against that consciously. Fighting medical gaslighting. If you encounter it in the doctor's office, it is worth having a conversation about. It might mean you need a new provider. It might mean your provider also needs some reframing, some training, maybe a nice little talking to, right? and acknowledging knowledge gaps and that providers are not all knowing. You know, it takes a village, and sociology can be a slow-moving field and isn't always respected. It's probably never respected in the way it should be. So it is a big part, I think, of the job that we perform all of the time to help educate in a way that is accessible, not only to our patients and clients, but to the providers that we're interacting with, to help bridge those knowledge gaps for them as well. And of course, listen to women. Did you want to do a little bit of Q&A? Sure. All right, cool. Thank you.
Okay, I ask that you raise your hand. I'll bring you the mic, and please wait until the mic is brought to you so everybody can hear your question.
Thank you so much for sharing your story. As a patient, I could actually relate to it. A lot of my journey through multiple different healthcare systems across the world has been the same, and it's painful that we go through that. What I want to ask you, Emily, is you mentioned being a daughter of a doctor and knowing doctors. Was it easier for you to advocate for yourself and ask for what you need? Because I find that for me, as well as the community that I represent, it's always hard to remember that the doctor works for you and it's not the other way around, and you've been gaslit and conditioned all your life since teenage or since childhood. It becomes really hard to fight or hard to say, no, I know something's wrong with me, please help me. So was it easier?
Yeah, it's a great question. I think maybe in some ways yes, in some ways no. I think the ways that it made it easier was that I grew up bringing dinner to the hospital. My dad was he's retired now, but he was a pediatric intensive care doctor. And so I would hang out at the hospital, right? And I was very comfortable in those settings. That in itself was not scary to me. But, it's kind of a different type of medicine, right? I was used to seeing him in settings where he was doing critical care. And there's very specific steps that are taken, and I got to follow a pediatric cardiac surgeon around for a couple of days, and I got to see those very specific steps that you take to do those surgeries. And when you have conditions like mine, that's not how it goes. And so I think the flip side of that was that I was so used to thinking that doctors had the answers. And so it was especially discouraging to me when I would go to a provider and then they would send me to another provider and then they would send me to another provider, and I was like, what's going on? Why is there no answer? Why hasn't the medical system figured this out? Why isn't there a better way to diagnose endometriosis besides literally having surgery and being cut open? And so I think that in some ways, yes, it was helpful in the comfort level, and in some ways, I think I kind of went through my own crisis of belief around the medical system and where that fits into how different parts of the medical system can help different patients. Thanks for the question.
Hi. Thank you very much to both of you to share your stories. I know it wasn't easy, and I'm so sorry this is the last presentation because this room should be fully packed. You did a wonderful job. I live with a chronic condition. I was diagnosed with MS at 23, and most of the time it was, but you look so well, and it's invisible. Either that or, have you been drinking? You look like you're drunk. So now I'm 53, 29 years later, and I do realize I was in denial for 10 years, and community is what helped me. I've been in healthcare for 30 years, so I thought I could figure it out. I'm still failing all the time on helping myself, but I became an advocate because I know the system, at least through my eyes. But I just want to thank you so much. My cousin has EDS, and as an advocate, I try so hard to help her, and I I don't even do a tenth of what she needs, and endometriosis also. And so I just thank you so much for being here today.
Thank you for all the work you do.
Your stories are sadly familiar. I just looked at the number of providers I have on my chart, 29. And I do not have a diagnosis. They think it's systemic sclerosis, sine scleroderma, but they can't prove it. I had the head of interventional radiology who had just completed a Tesla 3 MRI on my spine with contrast at my request so that my OB-GYN could use it as well. And that doctor told me, you know, there's really nothing wrong with you. You just need to drink some sort of a tea, I forget what it is, and take turmeric. And I said, what about the findings on the radiology report that says that I have adenomyosis? I think I killed the word, but he said, oh, that's not important. Let's talk about something that is important, which is your spine. I think we need to do some spinal injections because you've got root compression on L4 and L5, and that's what we did. And my OB-GYN looked at that report and said, he said, what? And I am a survivor of invasive lobular carcinoma, which is only 10% of all breast cancer. And I'm fortunate to have an OB-GYN who understands the implications of ILC. And he said, no, when I told him about you just need to drink tea and take turmeric, he said, oh yeah, that'll fix it. And it's funny, but it's not. I had an open hysterectomy and bilateral oophorectomy, and I'm 65 years old, and when it was done, he said, there was just a whole lot of stuff going on there that shouldn't be going on for someone your age. And sort of the way I understand the condition I has is it was the reverse of endometriosis. Instead of growing inward, I grew roots into the muscular structure that holds the uterus in place. And he said it just would have continued to grow and grow and grow. And both of my sisters have had vaginal prolapse. So I was probably headed there too. But I really only needed to drink tea and eat turmeric.
I was told that the ulnar nerve symptoms that I was experiencing post-surgery were because I was too stressed. So, you know, we can drink some tea and chill out together. Okay. Yeah. I'll bring the turmeric. Perfect.
I'll be joining you. Hi, so fellow zebras, I'm actually also a hypermobile EDS patient. I also have autoimmune conditions, and I'm not sure if it's the same condition that you were talking about, but maybe it sounds like it. I didn't have endometriosis, but I had adenomyosis, which is when it's grows inside the tissue. And had significant amount of pain. I'd had bloating. I looked probably about 4 or 5 months pregnant. I'd had a whole bunch of things going on, and a GYN who just said, oh, well, maybe it's intestinal, I'll go see a GI doctor. Took me, I don't even know how many doctors to get my lupus diagnosis and to get my EDS diagnosis. But when I was seeking them out, first of all, very often this is another barrier that patients with these kind of conditions run into. So say I was looking for a rheumatologist. I have a diagnosis of fibromyalgia, which for years is what everybody just umbrellaed all of my symptoms under. And so when I was seeking a rheumatologist, I lived at the time in the Seattle-Tacoma area where we have lots of doctors. In that entire area, because I had a diagnosis of fibromyalgia, there was one rheumatologist who would even let me come in his door. That's it. And thankfully, he was a rheumatologist who listened, and he was who diagnosed me with lupus and helped me get into a genetics clinic, because here's another issue with getting diagnosed with something like this. If you tell a genetics department that you think you have hypermobile Ehlers-Danlos, they will tell you exactly like what you guys said, oh, why do you need a label? But they will really, what the first line out of their mouth is, well, we don't see patients who have hypermobile because there's nothing you can do about it, and so there's no point in a diagnosis. And my response to them is always, there may be nothing that you can do directly for EDS, but what about all the secondary conditions that are known to come with Ehlers-Danlos? I don't remember which one of you mentioned it on your slide, but small intestinal bacterial overgrowth, mast cell activation syndrome, autonomic nervous system disorders, all of those things are like part of this whole package. And if you don't know that you have hypermobile Ehlers-Danlos, you're not necessarily going to know to look for those, because none of those things are super common. SIBO is probably the most common out of those. You go to an immunologist and they're going to diagnose you with chronic autoimmune hives rather than MCAS, So those are also barriers that I've run into, and I've usually had success breaking down the genetics barrier by making that argument, but I hear it, I've heard it for clients of mine, I've got a daughter with it, I've got a sibling with it, and it's insane. So I want to shift really quick to a different thought, and then I'll give it back to Nancy. The supports, how do we as advocates support our patients who are going through something like this? First, you had mentioned just hearing them, listening to them. I always like to think of, at the beginning session, one of the presenters had mentioned Brene Brown, and she is amazing. If you don't know who she is, you should check her out. But she talks about empathy not as walking in somebody's shoes, but as walking next to them on their journey and believing them. And that belief is what a lot of the people that we work with need, especially in a case like this where they've been gaslit, they've been abused, they've been dismissed. That's a key component to building that trust. One of the things I think about in terms of the belief and social supports is the mindset that I've generally run into, and I'm going to read this because it says it really well. Stay sick and you're not trying hard enough. Make improvement and you were faking all along. Share your reality and you're seeking attention. Keep the struggle to yourself and you aren't really sick.
We are at our time, but we are going to take one more comment. Thank you. If you want to stay, we would absolutely love that. So one more comment on this.
I also do have one question for Emily at the end.
Hi, thank you ladies both for sharing your story and your experience. It's really saddening to hear that, but it's all too common. I had a question. Shay, something that you mentioned, a lot of great things that you mentioned, but something specifically that you said that really kind of stood out was you found providers that resembled you and were a reflection of you, which as an advocate is the single most difficult and challenging thing that I run into. I mean, there's many challenges, we all know. But that's one of them, and I just wonder if you had any tips or suggestions on how to do that.
I was fortunate that I actually met the doctor that I made my doctor through taking a client to her. I was working for a nonprofit, so I kind of just started meeting all these doctors when I was serving the clients for the nonprofit. But when I am looking for clients now, I do my best to look through reviews, and I do my best to look for, any kind of history or in their like philosophies of care, things like that, that indicate that they, if they do not share a cultural basis or some kind of like same ground there, that they at least have some kind of equity awareness or some cultural training. Like, you can actually see if certain physicians have like DEI training. I forget if it's like a particular specialty, but I've seen it on several profiles, and that always feels encouraging. And just generally, when I'm doing intakes, I talk to my clients about what's important to them. And so some of my clients could not care less, right? And most of those clients are white. But, you know, some of my clients, it is really important that they have someone who speaks Spanish, because they might need to interact with their family as well. Or, you know, some of my clients would really prefer someone who's queer. And that is something that I probably have a little bit of an edge on, because I've been in that community my whole life and, you know, talking to friends about their doctors, right? I'm also fortunately, again, in the Bay Area of California, so it is a more diverse metropolitan area, but there are also directories. I wish I had them on the top of my head. I don't. But there are directories that specifically talk about providers that are informed on certain conditions in certain ways, like that are allies to communities, and that have basically like come with referrals from patients, right? And so Facebook groups, Reddit even can be really helpful if you know where to go and know where not to go. But Instagram, sure, yeah. So social media can be very helpful, for sure. Thank you.
Well, thank you so much to Emily and Shay for sharing all this information with us today. Will you two be available out in the hall afterwards to for questions or anything?
Happy to stay in the hall, and anyone who's specifically interested in talking about EDS-related things as well. My good friend Maggie Buckley is here, who is an advocate, and we're happy to talk through some of that as well if you want to talk specifics on that. But happy to answer any kind of questions you have.
Well, thank you once again. Please show your appreciation for Emily and Shay on this topic this afternoon. May you all have a very safe journey home. Thank you for this wonderful week, and if you have questions, they will be available for you.